Like a phantom. You're everywhere. Dr. Kini, there you are. Number 8, HK 45.
There's a distal lesion.
Case number 8.
Yeah.
Okay, we have a 45-year-old male with a new onset of angina who actually presented to the emergency room. So he does have risk factor. And then, since he ruled out, he was sent for a stress test. Stress test ETT, if you see, he had a Duke score of -10, but he had balanced ischemia. And because of that, he came for a cardiac cath, which had shown significant 3-vessel disease.
Okay, show us the significance so we can
So
believe
EF
you.
is normal.
No, we can't see anything. We are seeing your face. Show us the angiogram, please.
So he had a 90-95% lesion.
No, we're still seeing the TAVR.
TAVR looks good.
TAVR looks good. Thank you. Oh, here we go.
Okay.
Nice.
So the circ was intervened already. So here, today he's for
the LAD.
diagonal bifurcation.
Yeah.
Finally.
And we are doing this case radially.
Oh, good.
Finally.
Finally. Oh, good. Dr. Barman does a lot of our radials. Everyone does radial, but I think he's really a proponent. And
He's a
wanna
big
just tell
proponent
us,
of radial.
Yeah,
So
I know that,
lobby
are
for
you
14
using left or right radial, or when are you choosing what, how, tell us. And
No,
how
this
will you be able to penetrate
he'll tell you.
radial? Dr. Barman.
I think our default is right radial unless the patient is older age. With the structural program, a lot of caths prior to TAVR in the elderly folks will do left radial. Certainly if they're short stature. And of course, if it's a post-bypass patient with a left in situ left mammary graft. Again, we'll always evaluate both pulses, so that might inform the decision as well. But just from our kind of custom, we prefer the right radial. There is slightly more radiation, obviously with the right radial, but operator comfort is greater.
But actually you have a very nice radial boards now, where once you can get the access on the left side, you can bring the hand closer, and then the board itself will flex so that the left arm is across, and you'll be able to do it in a better way, and especially in elderly patients, women, I think who are, I would say, 75 and above, radial should be done. So just going over the steps, I think everybody agrees this is a diffuse, means a long LAD diagonal bifurcation 1-1-1.
Yeah, so it looks like you're going with a 2-stent technique, because I'm seeing you already doing a lot of work in that diag. If this was provisional, you would just be working in the LAD. So tell us how you made that choice and what your strategy is.
Yeah, so if you see here, the involvement, it's a 1-1-1, and disease of
Show us
ostial
the
diag.
angio, please. Put that up, please, so we can see what you're talking about.
So if you can see, look at the angiogram.
Nice. Yeah.
So you would say 90-95% of the LAD, plus more important diag ostium, right? Is 80-90% diag ostium. So I think if they can start showing us the bifurcated app, that's where you make a decision. If your side branch is more than 70%, and your large, means the length of the side branch lesion is definitely more than 10 millimeters, and the size of the side branch, like you see here, 2.5 and larger, you got to consider 2-stent strategy, and that is what we are going to do here.
Yeah, I think everyone is in agreement here. Large side branch, diffuse disease, no question. You wanna preserve that side branch for the patient.
Now,
So
only question would be the
and what's
technique.
the story?
Yeah, or technique that we should choose here. What would the panel say? What's the technique that we should use, 2-stent strategy?
No, I think, so we heard so much debate on the DK double,
Yeah, but that was for the left main. Yeah, that was, yeah.
Mostly for the left main. What do you think? Ron, which way do you go? Do you do mini crush here too, tap, or DK crush?
I prefer mini crush here, my personal. But I think that all of the above are okay. I mean, you can do culat, you can do mini crush, and you can do tap. The tap, I think the issue is to get closer, not to miss a gap. So that's you don't want to miss the gap of the ostium of the diagonal.
Jeff?
Okay,
you
are
definitely
they
don't wanna
showing
miss the oscar
app
of the
there, so
diagonal.
we can show them the steps or no? So essentially what will happen is, I agree with Ran. I think as you see, the DK crush has a lot of comparison, but mostly with the
Left
pull-out
Right.
or provisional stent technique that has never been compared to mini crush technique. And I think high volume operators always like, well, if you say, would you go for DK crush versus mini crush, would definitely prefer mini crush since the steps are fewer.
It's less steps.
Yeah,
it's
Yeah, less
faster.
steps and the
Make it
same,
simple.
same thing
Right.
done faster. Yeah.
Yeah, so I
So-
think the whole panel is agreeing with you, Jeff.
Yeah, I agree. Mini crush, I would not do a collide. I think, personally, I think that ends up with a lot of metal in where you don't need
Yeah.
it. But the mini crush, I think, is the way to go.
Mini crush, everyone is
I agree.
saying.
Crush.
So the
DK.
sizing, how are you deciding the sizing here? This is
So
a
they
very
are-
long,
but-
diagonal lesion. I think it's at
We'll
the
go
very
with the
least.
2532 to the diagonal, and then we will take a 3028. But unfortunately, we have 6 French,
gotta leave that
right?
in
We'll
there.
go with the, you have 6 French, 7 French. We will have to show you the steps of DK crush now. We already show you the steps of mini crush.
I think we were chatting and we took this out.
Okay.
I think DK crush.
And I think I agree with
Because of the
Ron
where the
again.
wire goes through and the
No,
and the
there are
strut
2, 3
coverage, is that why you favor DK?
Yeah, there are 2, 3 reasons why DK crush is a good technique in this, because the main vessel LED is a very good size vessel. So even if there is some metal there, it doesn't harm too much. If it was a 2.5, I will go for a mini crush. But this is the 3.5, almost 4-ish vessel, and then
Also an Asian
almost
guy
a
with
3
smaller-
millimeter
smaller
diagonal.
radial
So-
artery, so-
And you think the DK crush is advantageous because of where your wire goes through and better stent
Yeah.
coverage at the ostium? Is that why you're
And
favoring
plus, the
DK?
chance of going through the stent struts while you're doing the final kissing dilatation is higher when you do a DK crush.
I think one important point that which they already discussed is recrossing is they say definitely higher when you do DK crush, because you already crushing it,
Put the other
recrossing and opening the strut of the side branch.
We'll put this one.
Are they showing the app there by
Yeah,
the side?
we can see
Yeah,
it. We
well,
see
Yes,
all
we
of
see it
that.
very
Don't
well.
worry.
It
You
looks
see
nice.
your
You're going to
case
the
and show us
diagonal
the-
first.
Yeah, so I go to the diagonal and then I will have the 1-to-1 balloon in the LED besides there. So we'll deploy the diagonal stent, then we'll take out the diagonal, the STS of the diagonal and the wire out. We'll crush it, recross. Okay, so now we have
You can see the balloon.
So we have to be very clear, at least 2 millimeters of the diagonal stent has to be in the LED, some die.
Yeah, otherwise you're going to miss
Yeah,
the
so
ostium.
what do you think? Go in the
Excellent,
right?
yeah. You can go for it.
Go in just a little bit, right there.
Good.
Go inside the
Sine?
Yes.
length, just a little deeper.
Yeah, I think
Come
it's
back a
good.
little bit.
I think come back.
Yeah, it's a promise. It's a promise to there.
Looks good.
Okay, good. I think that's it.
And is slightly short for this.
So deploying the stand and
That's
then the
it.
balloon.
12.
Oh, perfect.
Nice. So this is a
For-
32,
for same.
2532, 2 millimeters sticking in the main vessel. We go up again.
Neil.
Good. Down. So I will take out the balloon and the wire of the side branch.
Exclude a distal wire. And that dissection.
Okay, some die to see. Wait. Good. Looking good. The vessel is looking good. I'll take out the wire. And now we have the main vessel, the LED, which is a
Pull it back
3O
a little
balloon,
bit
the same
We're
balloon we
really
used.
watching
We'll crush it
your
now.
technique here.
Wait.
Okay, and now we're crushing.
And now you're crushing the stent back
Now we are
off, right?
crushing the,
There you go.
good.
And now you're
So I will
recross.
take out now the LED balloon, recross, and this is a key that when you recross and dilate the stent
leave this
strut, it
one.
has to be a non-compliant balloon. Huh?
Okay,
Yeah.
so
Leave
let's
this
show
one
us what you're doing with it. We'd like to see your wire. Which wire are you using to recross? Don't lose the wire in the LED.
Yeah,
you go.
yes.
She'll
leave this in
rewire,
there.
it's fine.
No, you gotta leave
What
it in
happened?
there. You're kissing with
It's
this.
there in the side. App is in the side.
You should take this out again.
Okay, so we see the app showing us. Now you're going to rewire the
Rewire
side
the side
branch through
branch.
the crushed stent.
What wire are
Which
you using
wire
to
you
recross?
This is the fielder wire which was in the diagonal. So same thing. If it goes easy, we are good.
With the 2 balloon?
Yeah, and Fielder is a very
What
good
I see
choice
you
for
do is
this.
go south, on just distal to it, and come back.
This
And
diagonal
grab
is
it.
not correct.
I think we didn't crush it enough.
And where are you trying
we
to
did.
cross? Proximal, mid, distal?
Usually I've
No,
seen them go
the
just
DK Crust
distal and
proximal.
come back.
Jeff,
and-
whenever it goes, it goes. You cannot be too selective here.
I always try, and not always achieve.
Yeah, but remember the DK crust people say go to the proximal strut. Otherwise, with the bifurcation teaching is go to the distal strut.
Yeah.
When the angulation is bad, sometimes I leave the wire and then open a third one
Yeah.
to help to guide. But this should be
No,
fine.
but she will get
No,
it.
the
just
only
have to take your
question
time,
is
it's
here,
fine.
did we crush enough, right?
It was a small balloon in the
No,
LED.
no, we did a 3-0.
Was 3.0?
Yeah.
Yeah, 3 should
But
be
you
it.
might use a larger stent anyway in the LED.
That was a 275.
There you go. Beautiful.
It's a top branch. Yeah.
Nice.
Okay, so now you will,
What about balloon we have?
2.0 compliant.
Okay, good.
Yeah.
so now you will dilate that opening into
The
the
soft is diagonal.
into the crushed area,
No,
into
hold
the
on. We don't
diag
have
with a
to have
small
so many things
balloon.
here.
You need to
Usually,
take that out. You never.
they chose a 2.0.
Wait.
Well, why didn't you take it out? Yeah, okay.
Okay,
Sorry. Here, hold this.
Okay, so now we will,
This is that's the LED one. Balloon. That's the LED one.
we did not take the balloons out.
okay.
Okay.
Okay, good.
Maybe put in the app reminder, make sure your balloons are out.
No, it is
Yeah.
there.
Pop up. Like I have so many pop-ups in my CAT reporting system for fellows to do the right report.
That balloon needs to
That
stay
you
out.
haven't done anything.
That's the LED
You have
twist
done
with.
this. They still make mistake. But put a pop-up. Make sure your balloons are out.
Okay, so now you're coming with a small 2.0 balloon to open that to make a little opening, right? Correct?
Yeah.
And then you
But
will-
with the mini crush, you would have been done by now, just FYI.
yeah.
No, actually, that was, Roxana had the interview in the DK Crush 5. Actually, you rightly said multiple steps. The key is that we don't have a true trial comparing DK Crush with the mini crush. Each have against the culotte and others, but DK Crush with this, and we had with the tap. But really, mini crush and DK Crush, I think still the jury is out there whether you really need to do these multiple steps which have been made for the DK Crush. But
Yeah,
you know it
except for
works.
the left main. The left main, I think the DK Crush.
Yeah.
Meaning,
Then it's
I think for
superior.
sure we're gonna break for lunch around 1:30 because I want everyone back in this room at 2:20.
LED.
But just to note, all of the case will continue to play. Although I can't imagine leaving, but if you want, you can.
But we are going to put a stent
We
in the
want to
main
just
vessel
put a
and then you
stent
can leave at that
because it's
time.
a lot of fun watching this.
So the key issue is you have to do pot at the end. I mean,
No, now we have to kiss, right?
yeah, but
Yeah.
at the end, don't forget the pot. I mean, everybody is excited
Before
about
lunch.
going lunch, so make sure you have a pot at the end.
Yeah, no, yeah, she will do the pot. At the end, but right now you're just opening the side. Now you're gonna kiss.
No, one
Should
other,
have taken them. Yeah.
see, one other key point that I want to make, that everybody talking about this, go to the distal strut when you're recrossing and all that. All the data is from the bench study, not from Vivo study. You can show up the slide of the OCT pictures of why you have to go to the distal and all that. Everything is a bench study.
So here
you
we
really-
have.
huh?
So here now you're showing us 2 non-compliant balloons, correct?
One is compliant.
One is compliant, one is non-compliant. Ideally, you have to do a non-compliant in the side branch. Go.
Yeah.
So that's the extra step also.
Go.
Go.
That's what your app says. Perform the simultaneous kiss. I'm reading the app to everybody
Down.
because it's small
They have
print.
2.0 balloon back.
That wasn't a real
This is
kiss.
like to take the instructions for use when you do the procedure, right? How to assemble a table that you bought in IKEA. You look at the instructions for use.
Open, yeah, that's
Instructions
3.0,
for use. Now here
28
comes the
cents.
kiss.
Good. Now get us the
There's
main
a
vessel
kiss.
stent. Down.
So now you're gonna put the LED stent.
Yes,
Yeah.
then you have to recross and kiss again.
And then recross and kiss, and you see that right now. Here comes you remove the balloon from both
the wires
vessels.
It's gone already.
This
The
is
main vessel stent is
radial.
coming. But you
Radial.
don't remove the wires, please.
How the agony
That
of the
has nothing
radial
to do
comes.
with it. The guy just flipped out. Oy.
Really kicked out.
Okay.
That's not part of the app.
Talking about the.
We had to pull the diag wire
No, I
anyways.
can just tell you, if it was mini crush, you'd be lunch, okay, by now.
I know,
let's
but it's
extend-
really nice, though. It's a beautiful representation of doing a DK crush.
What we do, what we'll do,
Huh?
we are
Can
going
you
to
like that?
rewire, put a stent in the
Unlikely,
LED,
'cause this is
and
too big.
No, we
then you
need-
go
yeah.
for lunch,
Get
but
it.
we'll continue on the side.
Yeah, exactly.
While you are,
That is a 35 wire.
that we are tying
Is it?
the wire.
Yeah, I got it.
Okay, I think what we're gonna do is, if it's okay with you, you continue, we have, the app is there. People could take lunch. I want everyone back in this room at 2:30. Thank you for going, I'll stick with you. I'll stay with you guys because I wanna see what you're doing. You're gonna bring that. This wouldn't have happened if this was femoral. I know that's what Dr. Kini is saying.
I am telling you, you're reading my mind. And then, and mini crush, 7th French mini crush.